Hospital, and I'm also the president-elect of IAP Delhi. So, on behalf of IAP Delhi and ICH, Institute of Child Health, we welcome you for this seminar today. So, first of all, I welcome Dr. Priyanka Gupta and Dr. Kamal Arora. I hand over to Dr. Priyanka, and then we'll introduce Dr. Kamal and start the session. Over to Dr. Priyanka, please.
Okay, thank you, sir. So, good evening, everyone. Today we are going to have a wonderful discussion on a very important and very common topic on IVH, intraventricular hemorrhage and periventricular leukomalacia. And IVH is the most common intracranial hemorrhage that is seen in the neonates, and it is a nightmare for any pediatrician and neonate. So we will discuss what is the pathology, how to manage, what are the complications, and how to counsel the parents. So over to you, sir. Please introduce, sir, and we can proceed.
So, thank you, Dr. Priyanka. As very rightly said, newborns come with very fragile vessels. That is why they get IVH, and they are born with little lesser brain. So, brain does not grow well. They get white matter injury, and PVL is just one of them. So, to discuss this topic, we have Dr. Kamal Arora. Dr. Kamal Arora is a dear friend. He is a DM neonatologist. He is taking care of a lot of newborns for last 20 years, at maybe more than that also, at DMC Ludhiana, and he's a prolific speaker and a very interesting personality. So he has been active member of IAP and NNF, and he has been gracing our a lot of platforms of neonatology and IAP. So I welcome Dr. Kamal on this platform, and I'm sure all of us are going to benefit from the deliberation by Dr. Kamal on ICH and periventricular and white matter lesions. Over to Dr. Kamal.
Sir, thank you for that wonderful discussion. Dr. Pankaj is my elder brother. I won't say as a friend, but I take so many advices from you, sir, always. And proud to be associated with you for so long, actually.
Thank you.
And I would like to thank the IAP Delhi IAP office for giving me this opportunity to talk on actually a very relevant topic, because it's like a nightmare, but that nightmare is preventable. So I'm talking about the disease which is preventable. So it gives me a pleasure that we can prevent this disease, and obviously treatment is little difficult, but we are not going to too much go into the treatment part. So I just share the screen, sir.
Sure.
I would like to request the audience for typing the questions in the chat box so that we can take up at the end.
Sir, is it I'm audible and my PPT is you're able to see the PPT?
Yeah, fine. Fine. Please go ahead.
So I'll start with that. Okay. Preterm brain injury, encephalopathy of prematurity. So I didn't take the topic first. I wrote it as we will talk about the IVH and the PVL, but I deliberately wrote that as it should be an encephalopathy of prematurity. And there are so many preterm brain injuries. Even though we will be talking about IVH and PVL today, but there are something like bilirubin encephalopathies in the preterm babies. There can be a HI in the preterm babies. So there are hypoglycemic brain injuries. But we, as a concern, is for the IVH and the PVL. So I'll discuss some part of the how the brain is formed during the phases from 22 weeks till 40 weeks, and specifically during 22 weeks till 34 weeks, so that we know that what we are talking about actually. Rather than jumping onto IVH, because everybody will say, I know the Volpe classification, I know the Papel classification, I know the De Vries classification, but what to do about it, why I can't prevent it, and why I should prevent it. So these are the two important concerns we'll talk about at the end also, and we are always happy with the questions. So please take active part in the discussion. So the first important is why we are talking about this is because there is so much of increased survival of the preterm infants in the recent years. So we are having our DMs, we are having the fellows, we are having the own centers coming up. Somebody is getting trained from India, somebody is trained from outside. But I am worried about, okay, the baby is surviving, but is the baby surviving and the intact survival is there for the neurological outcome or not? It is same thing which we always talk about the ROPs. The baby is surviving, but I am surviving a blind baby. Is it worth or not? So it is not late enough that we will be getting the cases, medical legal cases, that my baby had an IVH and it was a preventable disease. My baby had a PVL, it was a preventable disease. Why I am suffering through this? Same as ROP, that it was an oxygen which was a part. Then here they will talk about the carbon dioxide as a part. So a preventable thing will always be, should be the most important, that you have to take care about it. Okay. So premature infants comprise a substantial proportion of the infants nowadays, and disability in the subset exceeds more than 50% of the most studies. So just to be on the lighter note, I was discussing with one of my pediatric neurologists, and I said that how is it possible that you are taking care of so many babies who are having cerebral palsy, who are having this PVL? So आपको लगता नहीं है कि आपको डिप्रेशन नहीं होता ऐसे बच्चे देख के जिसमें मैं कुछ नहीं कर सकता? So he said, शुरू तो तुमने किया था ना, ये नियोनेटोलॉजी वाले ने शुरू किया था ना, ना बचाते ना बच्चा ऐसे आता. So that is on the lighter note, but we have to work on this field and get the most intact survival babies here actually. Fine. So there will be many parts in the nutrition part, the ventilation part, the developmental supportive care. So there will be many factors which will come across. So first, most important is the development part. So major events in the development are the primary neurulation, which happens from the first 3 to 4 weeks. Then the prosencephalon development from 2 to 3 months. Then neuronal proliferation, then the next 3 to 4 months. Then neuronal migration. So after the proliferation, we have the migration, which is 3 to 5 months, a very important part. We will discuss this part in detail. Then we have the organization of the brain. Then that is 5 months till it happens for the years, 2 to 3 years that happens. And myelination keeps on happening for many years, even after the birth. So the primary neurulation, the prosencephalic development, the neuronal proliferation, neuronal migration, the organization, and the later on is the myelination. Okay, so just a minute. Yeah. So multiple active developments are happening from 24 weeks till 40 weeks of gestation. So important thing which we don't discuss in our daily routine is something is the subventricular zone. There is a proliferative cerebral dorsal subventricular zone and ventricular germinative epithelium in the ganglionic eminence. What does that mean? I know there are terms which are getting introduced. So we'll discuss where it is actually happening. So there is subventricular zone, which is below the ventricle, and there is ventricular germinative epithelium, which we discuss when we talk about IVH. That's why I'm discussing here. Let's start from the germinal matrix at the ganglion eminence. Then we'll discuss something about the subplate neurons, the oligodendrocytes, the microglias, the axon, thalamus. I'm not going to discuss about the thalamus, cortex, and cerebellum, but I'll stop at the oligodendrocytes and microglias. Okay. So what is subventricular zone? It is a paired brain structure which is happening on the both sides of the brain. It's situated throughout the walls of the lateral ventricle. Throughout the walls of the lateral ventricle, this is present, and there are 4 distinct layers of the variable thickness and cell density as well as the cellular composition. So there are different layers in the subventricular zone which have different densities at different gestations. So there are somewhere there are neurons which are sitting below it, then the neurons go up. So their layers keeps on changing and the thickness keeps on changing as the gestation increases. The subventricular zone in humans beings appear early in gestation, that is nearly around 18 to 20 weeks of gestation. Usually we say less than 20 weeks, not very clear at what gestation, but it is around 18 to 20 weeks of gestation. So it is present on both the sides of the brain, situated throughout the lateral ventricle walls, and there are different layers. Don't worry about it. We'll keep on adding to this. So don't imagine too much into your brain what is actually happening. Okay. Then what is subventricular zone? It is mainly neurogenic. So all the neurons are present there. So early subventricular zone progenitors give rise to the neurons of the deeper cortical layers, which means there will be a migration in there. So during the migration part, the neurons from the subventricular zone will shift onto the neurons on the cortical layer. So that's why this blue color line you can see, the subventricular zone, this neurons, the blue color lines, the neurons are moving up and they're staying at the deeper cortical layers. So the later subventricular progenitors, which are formed later on, give rise to neurons of the expanded upper cortical layer. So the neurons which are formed later, they go up, and the neurons which are formed in they're early, they stay in the deeper cortical layers. Fine. So that is about subventricular zone. Then is the oligodendrocytes. The oligodendrocytes, they are the myelin producing cells. So there are 4 sequential stages of the maturation of an oligodendrocytes. They have to produce the myelin because myelin is we all know the myelin is very important for the signal transmission. So these are 4 different types of oligodendrocytes. First is the progenitor. You can see the dendrites are 2 only, and there is some arborization at the end. Then we have the pre-oligodendrocytes with their somewhat arborization has increased. Then the immature oligodendrocytes, then the mature oligodendrocytes. So as it keeps on maturing, the myelin-producing arborization keeps on increasing. So the oligodendrocyte progenitors and the pre-oligodendrocytes, they are the pre-myelinating oligodendrocytes. Then the myelination happens when the immature and the mature ones. Fine. So pre-myelinating and the myelinating are differentiated. So if the baby is born like at 24 weeks or 22 weeks, I just have a progenitor. So the myelin is not formed here. As it keeps on maturing, I'll keep on increasing the number of arborifications, keeps on increasing, and the myelin producing keeps on increasing. And these are below, there are some of the markers, the biomarkers, the Ng2, vigamittin, CNP, GALC, sulfatide. So these tell us how they keeps on increasing. So as the number of markers keeps on increasing, the mature oligonucleotides keeps on increasing. Okay. So this MBP is myelin basic protein actually. Okay, so that's about subventricular zone, and then we have talked about the oligonucleotides. Only few important points I'm discussing here. Then the microglia. They have a key role during the brain development, and they involving the apoptosis. So wherever there apoptosis is happening, the microglia has to be there. They are prominent in the forebrain at 16 to 22 weeks of gestation. There's a peak abundance in the cerebral white matter in the 3rd trimester. So by the end, they keeps on increasing. I think everything keeps on increasing by the end. So oligodendrocytes, the microglia, the subventricular zone will disappear at the later stages. So they keep on happening as the gestation is increasing. They are the key factors of cellular injury with both ischemia and the inflammation. So we'll discuss something about PVL and the microglia at the end. So they have this, they create a cellular injury with the ischemia and the inflammation. These cells generate the free radicals, secrete injurious cytokines, and enhance excitotoxicity. So not a very good cells, but they are important. Then the axons. The axon development happens in the last trimester of the gestation and the early postnatal period. And protein 3 is expressed in the growing axons. So now important line, the white matter immunohistochemistry of the axon happens at 20 weeks. From the subplate, they move to the cortex at 27 weeks, and they reach within the cortex at 37 weeks. So the axons, they start from the white matter, they go up to the subplate, that is plate below the cortex, by 20 weeks, just enter the cortex at 27 weeks, and if they stay within the cortex, reach by 37 weeks. So if the injury or the baby is born at 24 weeks of gestation, I am still at the subplate and not entered the cortex. The axon is still low. So there is some injury will happen to them and the migration can be stopped here. So that's the problem, that axons should not be injured at that time. And the axons require a lipid, they require the carbohydrate, they require the glucose for their migration and for their working. So they are the nutrition plays a role here. So now, what is subplate neurons? Because I'm introducing new terms, the subplate neurons. So these are the first generation neurons. You can see this, I have marked it as red color, the round shape, the oval shaped. So these are subplate neurons just near the cortex. They just stay below the cortex. So these are the first generation neurons and they disappear during the postnatal period. They don't stay there. There's nothing in the postnatal period like subplate neurons. They are important in establishing the correct wiring and functional maturation of the cerebral cortex, which means that from the ganglion eminence, which we studied the subventricular zone, the neurons have to migrate, the axon, they have to migrate from the lower zone and reach up to the upper zone from till the cortex. Just a minute, I think I'll get a marker. Pointer options. Yeah. Can you see the pointer? Okay. Yes. Okay. Fine. So these are from what is happening from this zone, the subventricular zone, the neurons move up. You can see what is happening. This is the moving up, and they reach the subplate neurons. Then a cortical layer is formed, which is the deep cortical layer. With time, this cortical layer thins out, and the neurons migrate further in the cortex. So what I am saying is, they it is important in establishing the correct wiring. So a neuron starting with subventricular zone has to go to the auditory, or has to go to the ophthalmic, or has to go for my hearing, for the temporal, wherever they're going. It tells you where to go actually. The subplate neurons. They appear to be selectively sensitive to injury, such as hypoxia. Because if there is a acute hypoxia, this is affected. So there is a total hypoxia, then the thalamus will be affected. So they appear to be selectively sensitive to injury. So the hypoxia affects these neurons. I hope I'm clearing some of your basics of the how it migrates and how the neurons are formed actually. So why it is important to handle these babies gently actually. So subplate neurons, these are sites of synaptic contacts for so-called waiting thalamocortical or the commissural or association corticofiber efferents. Thalamocortical means starting from the thalamus, reaching up to the cortex. So thalamocortical association is formed with this before differentiation to the corticoplate. They are the functional link between these waiting efferents and their cortical targets. So they are the functional link between the waiting efferents, so what is actually coming, and the targets. It means like something like I have to reach up to the top. It's like my resting point. The subplate neurons are my resting point. I rest there and then I go up. They provide the axonal guidance into the cortex for the ascending efferents. So I'm guiding you where to actually go. So that is subplate neurons. Then they facilitate the cerebral cortical organization and the synaptic development. So the subplate neurons are very, very important because they are the waiting thalamocortical efferents actually. So they will guide everything where to go actually. Okay. Then there is a migration. Another important thing. So migration is something like I have to hold a stick and I have to reach to the top and go around in a migratory fashion, like a rotatory fashion. So the peak period is from 3 to 5 months, and the migration happens in all the zones. So you can see in the center, this is the ventricular prominence or the ganglion prominence, and the neurons are going in all the directions from here. So we can see in this diagram, this is a cut section actually from the ventricle to the cortex. So this is the ventricular zone, the blue one, ventricular zone. So what is happening from these are the radial glial fibers along which the neurons have to migrate. So the neurons are migrating up. They're going like a rotatory fashion, going up, up, up. And this is intermediate zone. This yellow color, this is intermediate zone where the neurons move up. Then they stay at the cortical plate and then they reach the marginal zone. So cortical plate can be thickened in the earlier gestation and they keep on decreasing as the gestation advances. So if you see the cut section here, there is a trailing process of the neurons. There is a process of radial glial. This blue color is the radial glial cells, along which this trailing process of neurons move. This is like the nucleus, and the diagram is for the axons. So nucleus, then migrating neuron, and the leading process of neuron. So a trailing process, a leading process, and then the center I have the nucleus. So it moves around in a rotatory fashion up. The most important thing is these neurons and the radial glial fibers, they require the lipids for the energy to move up. So if a baby is born at 24, 25, 26 weeks, and I am not providing the lipids to this baby, the neurons will definitely slow down or stay in the subplate zone, or they may not even migrate at all if you don't provide lipids to these babies. So nutrition plays a very important role. Sometimes we get that I can't start the lipids because there is the risk of sepsis, there is thrombocytopenia, so many things. So I am not providing the lipids, the small lipids or whatever lipids we have, or the nutrition. So there are people now, they talk very aggressively about the nutrition, that NEC will not happen to many of the babies. You are just worried about the NEC. Don't worry about it. Start with the trophic feeds, start with the lipids, and go fast. So as soon as you reach the full feeds, the milk is providing you everything. The lipids are there, everything is there. So nutrition will play a role in the intact neurological survival of these babies specifically. Okay, so this is just for your briefing. Actually, this is not a very important slide. The growth cones crawl forward as elaborate, the axons training behind them. So they keep on moving and the other neurons follow them. It's like you will see the ant moving. So one neuron moves, the second neuron moves. They keep on sending the cues to these ultimate neurons. So these are the growth cones. I'm not going to detail of this because there are so many genes in our homing box genes, fibronectins, heparan sulfate genes are there. So we'll go just again this. So the peak time period, I think you got that what I wanted to show here. The peak time period is 3 to 5 months. To function normally, neurons must migrate to the brain's cortex or the outer layers and the other structures. So they have to reach from the ganglion eminence to the top. So again, the same slide we are saying the inner layer of the brain, that is the ventricular zone, going up to the migration zone, then the cortical zone, then the marginal zone and the outer layer of brain. Then we reach the cortex. Okay. So the cerebral connections keeps on improving. So now what you see here is, now again, this is actually electron microscopy picture of the brain, where you see the subventricular zone at the below, then the intermediate zone, then these are the subplate neurons. SP is the subplate neurons. These are the waiting neurons. Then the cortical plate, then the marginal zone. So in a 24 weeks preterm infant, there will be a thick subplate zone. You see, this is a thick subplate zone. So these are waiting neurons. They have to go up. And this has to keep on getting thickened as with the time. And the subplate neurons have to keep on getting shrinked. And these are the thick subplate neurons and initial lamination and the first thalamocortical inputs to the cortical plate. So these are sending the cortical, these are neurons to the cortical plate. Okay. Then what is happening further is for a transient pattern, we see as what we are seeing as cerebral connections. So what is happening here now you see is the 34-week preterm infant transient circuits and subplate zones are left and this is getting thickened. So intermediate zone is there, the subplate zone will get smaller and smaller and it will keep on getting thickened. So this is what I wanted to show. This is a diagram for a baby where you will see like this. Okay. So what you are seeing in a 20 weeks infant, there is a subplate neurons which are thickened and there is subventricular zone is there, intermediate zone is there. Then with time, the cortical plate getting thickened, the cortical plate getting thickened, the subplate neurons are left with hardly anything. And this is all now the cortical plate up. Fine. So this is the migration happening. And you see, this is a very smooth brain. This is getting some sulcine gyri, more sulcine gyri, and more sulcine gyri, and this is getting thickened. So this was just a layer here in the subplate. This was subplate neurons were thickened, and now there is hardly any subplate neurons, and everything has reached up. So by 40 weeks, everything will reach up. Clear? So so I think you got what migration means. So now the thalamus receives its initial neurons early in the second trimester from the diencephalic ventricular zone. Just in line you have to read. There is second later wave of neurons that are generated in the ventricular telencephalic this eminence and migrate to the dorsal thalamus. They go down. These neurons are mainly GABAergic and migrate to the homotypic neurophilic interactions. So I'm not worried about this too much now. I just want to say that there is some zone which is moving up and moving down now. So the thalamus move down. Yes. Okay. So cerebral cortex. So most of the neurons of the cerebral cortex are migrated and the proliferated dorsal telencephalic this subventricular zone before 24 weeks of gestation. Subsequent events include development of regional, laminar, and cytotoxic complexity will keep on happening. After synapsing on subplate neurons, this leads to striking 4 times increased cerebral cortical volume. The cortical volume keeps on increasing. Thus, this critical phase of cortical development occurs simultaneously with the premature period. So if you get the development on this brain migration, so less than 20 weeks, there is subplate layer apparent at approximately 10. I told you that 18 weeks of gestation nearly. Invasion of the subplate by thalamic efferents, increase in size of the subplate happens. From 20 to 24 weeks, thalamic efferents are there, axons keeps on getting increased. And from 24 to 32 weeks, there are thalamocortical afferents which enter the cortex and the subplate reaches maximum size by around 27 to 30 weeks, which keeps on getting decreased. And from 30 to 36 weeks, the cortical fibers enter the cortex. Cerebellum, we are not talking about. Coming on to the injury. So I think it was a tough, I know it is very tough onto the brain that when we talk about these things, what are subplate neurons, what are this neurons, but keep on remembering this. Why I was talking about this was that you should know what is the basis, why we are talking about the PVL, IVH, GMH, hypoglycemic brain injury, why we are talking about them, why we are talking about the nutrition actually. So now, if you know that the 2 major injuries are the PVL and the IVH. So I'll talk about some terminologies, and then we'll go to the PVL first. Okay. So IVH is GMH IVH. So the nature of problem is capillary bleed from the germinal matrix. So germinal matrix is that ventricular eminence which we were talking about. And that's the place from where the neurons have to go around. So it is nothing actually. It is just you can say capillaries. Hindi में पंजाबी कह लो. It is like a गुच्छा. वो सारे neurons वहाँ ऐसे पड़े हैं. They're just getting a blood supplies, and there is a capillaries. There are not the vessels. There are capillaries which don't have a wall, and the wall can rupture anytime. Just a fraction of your high blood pressure happens there. The baby is gone. So you are giving the baby has a high blood pressure of around 25. You just give a epinephrine, and the blood pressure goes to 40. There will be a rupture. Next, you do an ultrasound after 3 to 4 days, you will get a bleed, maybe grade 1 or grade 2 bleed can happen there. So then there is periventricular hemorrhagic infarction or the PVH. So it is grade 4 IVH is also known as PVHI. So these are different notations, and these are not from the capillary bleeds. They are the venous infarct or the medullary vein. Because we keep on discussing that the GMH and the IVS grade 1, 2, 3, 4. The 4 is a separate notation as compared to the 1, 2, 3. That is the capillary bleed. These are the venous infarcts actually. So we don't confuse these two terms. Then this for the IVH. Then for the PVL, there is basically arterial cytokine damage. Is the arterial cytokine damage, and there is a necrosis in the watershed areas, either by ischemia or something like that. We'll discuss them. Then there is diffuse periventricular this damage, that is white matter damage, that is diffuse injury to the oligodendrocytes or oligodendroglias. Okay. So we are nowadays getting more of the diffuse PVLs, focal PVLs hardly we get because we have a better ventilation strategies, but because diffuse PVLs we can't prevent, and these are picked up by the MRIs. I think we know these terms already. So IVH, PVH, focal PVL, and diffuse PVL. So first we are discussing about something about the PVL. I think I have around 15-20 minutes more actually. Okay. So PVL, it was the discussion started by the virtues in that was 1867 by happened in the periventricular location. There is something happening. Then in the later it was Banker and Larky, which came out that there is cellular evolution, something venous stasis, circulatory insufficiency. So there were different pathophysiology which were discussed, and they affect the premature babies actually, not the term babies. So these were some discussions happening from 1867 to 1962. The incidence of the cystic PVL is detected by the cranial ultrasound is 6% to 10%. But currently, that's what I told you, currently it is decreasing to nearly 3% by the MRIs. So cystic PVLs, we'll discuss why the cysts happen actually. And non-cystic PVL is on the rise. But it is difficult to ascertain. It happens from 21 to 79%. So if I divide that there is a PVL, there is more of a non-cystic PVL, which we call as diffuse white matter injuries, rather than the cystic PVLs. So these are detected by the cranial ultrasounds. Hardly anything, because you can only detect the cyst. You can't detect on the cranial ultrasound this non-cystic PVLs, because there is nothing like we can only say there is a flare on the ultrasound, but we don't see a cyst. So flare is like grade 1, which looks like that it is okay. Okay. So I made this diagram of this sort that you can understand where the lesions are actually happening. So in the center we have the ventricles. These are the white matter areas. You can see this part. So this is the caudate nucleus. This one, the caudate nucleus. These are the lateral ventricles, and below we have the thalamus. So this is a germinal matrix. So where this is coming up along the lateral wall, there is a germinal matrix or the ventricular eminence from where the neurons have to migrate up. Okay. So now this is how our body is represented: the leg, the trunk, and then the arms. I think we all know this. And this is where the focal PVL happens. So the PVL starts from this side, from the ventricular center, and moves towards the lateral side. So leg, then the trunk, then the arm. So focal PVL happens here. This is just a diagrammatic representation to understand you that the legs are affected more in the PVL as compared to the arms, because this leads to spastic diplegia. Rarely you will find a spastic quadriplegia here. You will find a spastic diplegia happening with this PVL. That's what we call as clinical correlate of the PVL. Okay, and if there is a diffuse PVL, it can affect everywhere. So more so it starts from this part, the central, so more so on the legs, then the trunk, then arms, so it can affect everything. But this is, you have to remember that the legs are more affected than the arms. The spastic diplegia is a clinical correlate of the pathology that is PVL. Okay, so what are the pathogenesis? How can I prevent it? So I should know the pathogenesis from where it is actually starting. So the initiating mechanisms are the ischemia and the inflammation. So the ischemia and the inflammation. Ischemia happens maybe due to us. Inflammation happens maybe due to the sepsis, which the mom can give, we can give, anybody can give. So the causes are basically maternal intrauterine infection, the postnatal sepsis, so the mom infection, the postnatal sepsis, hypotension. Hypertension usually doesn't lead to this hypotension, which leads to ischemia that happens. Hypocapnia, hypocapnia because if the CO2 is low, so what will happen to cerebral vessels? They will constrict, and the ischemia will happen to the brain. Then hypoxia, acidosis has the same features, acidosis. So these all lead to excitotoxicity and free radical attack. Yeah. So I have made this algorithm. You can see this a flow chart. So all things start from where? The prematurity. So if I can prevent the prematurity, I can prevent PVL, IVH, ROP, anything. So the first important thing should be that you should prolong the pregnancy or the gestation as long as possible. So prematurity, what is adding to onto it is the maternal and the fetal infection. So they are correlated with each other. If there's a maternal infection, can lead to prematurity. The premature babies are delivered because of the fetal infection, or they are predisposed to this. So this always there. So prematurity due and adding on to the maternal fetal infections leads to ischemia and then the reperfusion. So what happens with ischemia is the arterial end zones are affected, and there is something what we call as the pressure passive circulation. This is a very important line when you talk about the preterm brain. What is pressure passive circulation? Pressure passive circulation means that if my I usually ask a question that what is the most common symptom for you adults having a high blood pressure? It is not the headache. It is nothing. It is no symptoms. Nothing. Because when they will say कि पहले तो नहीं था बच्चे हमें adults I'm saying to us there is nothing like a blood pressure was not there. ये तो अभी पता लगा हमें because everybody said headache. Because headache happens when the blood pressure crosses 160, 170, 180. What is happening from 120 till 180? No symptoms. Why? Because we can tolerate that much of a pressure. The cerebral blood flow or the cerebral perfusion pressure is maintained. But what is happening to the newborns? As soon as BP rises to 40, the blood pressure increases, the pressure increases in the brain, the cerebral perfusion pressure increases in the brain. This is what I want to show. For a term baby, this dark line, from 40 till 80, they can tolerate this cerebral blood flow. Even this blood pressure gets high, you see the blood pressure is getting increased from 40 till 80 or 50 till 80, but the cerebral blood flow is almost the same. But after 80, it also loses, and the BP will go up. But what is happening for the preterm baby, this dotted line? What is happening to this baby? There is hardly any margin for this baby from 20 till 30. So any blood pressure which increases in the body will immediately lead to ischemia and reperfusion injuries. So if I decrease the inotropes, BP goes down. I'm getting into reperfusion injuries. Then in ischemic injuries. As soon as I increase, I get into reperfusion injuries. So the margin where I have to act is very less. So this is known as pressure passive circulation. So whatever the pressure is in the body is getting passively circulated to the brain. Then adding on to it, the cytokines and the microglias. So microglial injury will happen. Cytokines will be released to the microglias. This increases glutamate. And glutamate is an excitotoxic amino acid. It leads to reactive oxygen species, ROS and RNS, which can lead to the oligodendroglial death. So this is what the PVL means actually. What is getting injured? Oligodendrocytes. So we discussed that they hardly have any the pre-oligodendrocytes because the babies are premature. There is hardly arborization. Even if that one injury happens to the oligodendrocyte, the myelin production will be stopped. So infection and inflammation are shown by multiple studies that increase the incidence of PVL with infection. Elevated levels of pro-inflammatory cytokines IL-6 in the amniotic fluid and umbilical cord has also been studied. Evidence of intrauterine T cell activation happens there. So there are studies which show that the hypocarbia and the PVL are strongly correlated with each other. The reason is the hypocarbia will lead to the vasoconstriction of the vessel in the brain, and it will lead to your ischemic injury. So then something which we discussed, the ventricular index. So in the ventricular index, so if it goes low, then what will happen? The CO2 will go low. This everything will be getting shut off. So PVL refers to injury to cerebral white matter, classically with two components, the focal and the diffuse. We already discussed this part. So the focal is macroscopic and that consists of localized like necrosis deep in the white matter injury, the loss of cerebellum, macroscopic in size, evolve into cyst. So these are cystic PVLs, readily visualized by cranial sound, but happen in less than 5%. And we discussed that the non-cystic PVL is microscopic in size, evolve over several weeks as scars, and this is also known as non-cystic PVL and not readily seen by the neurosonography, but can be seen by the MRI, and majority of the cases are a non-cystic PVL. So then in the diffuse PVL, there is marked astrogliosis and microgliosis, decrease in the pre-myelinating oligodendrocytes, which we discussed. That's why I told you that important is to understand what are these oligodendrocytes and where the injury is happening in the PVL. Later, they're counteracted by increase in the oligodendroglial progenitor. So you get a pre-term oligodendrocyte, but not the term not the mature, I would say, not the mature oligodendrocytes. So you are left with hardly any myelination which is happening there. So this is again, I have just shown you that this is what we are discussing, that these are the progenitors which lack the processes, do not have a capacity for full differentiation to produce myelin producing cells, and there is hypomyelination which will happen. I'll discuss something about to the premature babies, and the baby will not able to register because there is no signaling happening because there is no myelin sheath there. So neuronal and axonal injuries will happen. Is previously unrecognized accompaniment of the PVL. So these injuries do happen there, but not the majority of them. So we say there is a mild mental retardation in these babies, not a full mental retardation. They understand the things, they have the thing, but if there is a component of hypoxia along with this, with a PVL, then the axonal injury happens. So regions of involvement, we discussed the cerebral white matters, thalamus, basal ganglia, and all those things. So everything is affected by PVL, but majority is the periventricular area. So this is shown by the neuronal axonal studies have been shown by volumetric MRI analysis, because what will happen is the volume of the brain will decrease if there is injury to these areas. Okay, I'll just go forward because I have IVH to do. So cerebral white matter, the axon, cerebral white matter, axon projection commission, this I'm going fast. Axonal injuries by this. Okay. So this is what they want to show, that this injuries, the glasses happen. So advanced MRI shown that the decrease in the volume, decrease in anisotropy, decrease in of all these areas. So decrease in volume of all the thalamus, the cortex, cerebellum. So that keeps on decreasing. Again, the same thing, everything is affected here. So basal ganglia neurons, periventricular white matter injury. So diffuse periventricular white matter injury appears to be a milder form of injury than the PVL. Periventricular white matter injury is initiated through the targeted injury to the oligodendrocyte lineage, that what we discussed. Timing of appearance and regional distribution of susceptible pre-oligodendrocytes is the most important. There is relative sparing of the glial and axonal elements. That's what I discussed. So little injury will happen to the oligodendrocytes in that periventricular area. But if there is diffuse injury along with hypoxia, other elements are also affected. So the basis, I think we all should know this, the grading of the PVL. So this is Linda de Vries classification. The grade 1 is the persistence of flare. This is on the ultrasound, the persistence of flare. The flare is basically a white or the hyperechoic lesion which is seen along the periventricular area. So this is not persistence of flare. Flare is on ultrasound is seen a hyperechoic lesion. How do we define the hyperechoic lesion? Which is hyperechoic more than the choroid plexus. So if you compare with the choroid plexus, if it is more white, then it means there is a flare. And if it is persisting for more than 7 days, then it means there is a problem which will happen. So later on, follow up these babies. This flare evolves into small localized frontoparietal cysts. So what will happen is from the frontal area, it will reach up to this occipital and the back area. So flare evolves into small localized frontoparietal cysts. So that is grade 2. If there is extensive cystic frontoparieto-occipital leukomalacia, so it is going out to the back, it is going back. So this is grade 3. So the grade 4 is extensive subcortical cyst. So now all the cysts are joined together. We are getting extensive and a big subcortical cyst. So usually we don't see grade 4 too much. We usually see grade 1 and grade 2 more in the babies who have a very tremendous course, a premature baby having all these problems which we have discussed, hypocarbia, the blood pressure problems, the infection, so and so on. So what we discussed. So this is how we see. This is a sagittal section. You can see this one. So there is a flare present. So if this flare is persistent, this is grade 1. This is also grade 1. This is a coronal section. You can see small cysts are starting in the frontal area. So this is a frontal area. This is the parietal, and this is a temporal area. So this is a C2 section of the neurosonogram of the coronal section. So this is the small cysts. I think you can appreciate. So these are cysts little bigger, but they are in the frontal area, not going into the parietal area. So this is frontal or may reach up to the little bit to the parietal also. So these are grade 2 PVL. Okay, cellular injury we are not discussing. Discussing the clinico-pathological correlation. So we already discussed that the cystic PVL leads to spastic diplegia. Non-cystic PVL leads to spastic diplegia plus the cognitive deficits. These are usually observed later, usually in the absence of the major motor deficit. So these babies can walk, but you will see some behavioral defects happening, cognitive defects happening in these babies. Okay. So what will happen to the sequelae? What will happen to the end? So this will be so this area is ischemic. So what will happen? A glycosis will happen there. So what will be left there? Some ischemic cysts will be left. So it will look like a ventromegaly, which is actually not a ventromegaly, but it is a focal PVL sequelae. I would say a cystic area will be left there. So spastic hemiparesis can happens to PHI, involves lower extremities as much as more than the upper extremities. Okay, next one. What is IVH? Okay, already late. IVH. So IVH, I'll go a little fast here because I think we understand IVH better than the PVL. PVL is injury which we don't understand better here. So we already discussed this accorded nucleus, the lateral ventricles, the germinal matrix. This is grade 1 IVH, which is happening only in the germinal matrix, staying there. What will happen later is this will extend the grade 2, which completes almost like 50%, just below the 50% of the ventricular area in the sagittal section. Grade 3 is which covers more than 50% of the ventricular area. The blood is reaching up to this point. So this is grade 3. The grade 4 is IVH is something different. So it is like a PVHI, which is the the venous part, not the arterial part. That's why I made it blue. So you can see this is grade 1 IVH in the sagittal section. So this is the caudate nucleus in the front. This is the thalamus, and this is what we call the caudothalamic groove or the caudothalamic notch. So caudothalamic notch or the caudothalamic CTN, what we call. So there is some hyperechoic area which you can see, which is separated from the, not exactly like the choroid plexus. So you can see hyperechoic area here, and you can see hyperechoic area here. So these are the areas where the grade 1 IVH will happen. This is the grade 2 IVH. You can see this is happening in the lateral ventricles, which is almost reaching 50%. Some part is still left and reaching again going to the third ventricle. So this is grade 2 IVH. In the grade 3 IVH, this is now the ventricle has started little bit dilated and it is covering almost whole ventricle. So this is between grade 2 to 3, actually reaching the grade 3. So the lesion has increased, and you can see some dilatation is happening in the occipital horns also. So grade 3 IVH, again, this is more than 50% in the sagittal section, both the sides, you can see. And it is trickling down. So this is the choroid plexus which is left, and this is up is the IVH. Grade 4 IVH is separate notation, so that you are not seeing an actual grade 1, 2, 3, 4, but you are seeing there is some lesion happening here, hyperechoic lesion. So this is all grade 4 IVH. They don't follow the sequence. Grade 1, 2, 3, 4. No, it's not the sequence. 1, 2, 3, and 4 is the separate notation. So the pathogenesis general matrix or the subepidermal tissue overlies head of the quadrate nucleus. Just above that, we have seen in the migration and all those areas. They are composed of glial cells. By 26 weeks of gestation, will migrate to the surrounding cerebrum. The supportive tissue then involutes and disappears by 34 to 36 weeks of gestation. I won't say 34 weeks, it is 34 to 36 weeks. And maximum rate of involution is 26 to 32 weeks. So this is the place where the greatest risk of IVH can happen actually. This gestation, 26 to 32 weeks. And after 32 weeks, I usually correlate something. I don't know why it is always going in my mind, the ROP. After 31 weeks, the ROP starts. So you come out of the IVH, you land over the ROPs. So be careful when you are handling with these very tiny preterm babies. So, okay, the site of bleed, because I have to tell this part, the site of bleed appears to be thin-walled vessel in general matrix. So that is on a capillary bed. It is nothing but is a capillary bed. So arterial supply happens from the anterior cerebral artery by the Hübner's artery, middle cerebral artery by the deep lateral striate arteries, and the internal carotid artery by the anterior choroidal artery. So anterior cerebral, middle cerebral, and the internal carotid supplies happen. Venous drainage is to the medullary, choroid, thymocyte veins, which drain to terminal vein, which drains into the veins of Galen. So this is, you can see the perforating arteries on the up, the anterior choroidal artery, the striate branches, and the Hübner artery supplying here. So this is the area which is supplied here, all over. In the venous drainage or general matrix, you see, so this is the medullary veins, the choroidal vein, and the thymocyte veins. They all take a turn, and here is the terminal vein. This is terminal vein, and then they reach the intercerebral vein. So this area where they take a turn is the major area where there is a turn. At this place, the infarction can happen. So, and then they finally drain into the vein of Galen. So if you want to have an algorithm for this, like we had for the PVL, so in a preterm infant who is ventilated, there is a decreased cerebral blood flow because there is a passive pressure circulation. There is a fluctuating cerebral blood flow because you are giving too much of inotropes, you're giving too much of fluids. This increases the cerebral blood flow and the reperfusion injury can happen, and increase in the cerebral venous pressure can happen. So all this leads to the capillary rupture because the capillaries are vulnerable. There's endothelial injury which happens. The platelet and coagulation disturbance happen, and finally the fibrillatory activity happens there, and this leads to IVH. So I'm not going into the detail of each of them, but I'll just skip on this. But you have to remember this algorithm. There is a decreased cerebral blood flow, fluctuating cerebral blood flow. I would say the more important is actually fluctuations rather than the decreasing. Decreasing can lead to PVL, but fluctuation happens to PVL as well as IVH. PVL, IVH. So things can happen, and finally the capillary rupture happens here. So there are many factors. So because intravascular factor, vascular factor, extravascular factors, the fluctuating cerebral blood flow is the main factor because we discussed here. Increased cerebral blood flow because of passive circulation, rapid volume expansion, hypercarbia. Hypocarbia was leading to PVL, hypercarbia leading to here because the blood volume will increase. And the vascular factors, because these are already remodulating capillary bed, there is nothing, they don't have any type 4 collagen, they are nothing. So what will happen is just a blood flow increases there and the rupture happens. So vulnerability to hypoxic injury happens here because these are vascular border zones. They don't belong to any either the posterior cerebral artery or the anterior cerebral artery or this middle cerebral artery. So these are watershed areas. So there is high requirements for the oxidative metabolism. So these are factors which you should know. I'm just skipping them. So what will happen as a sequelae to these? So there's a post-hemorrhagic hydrocephalus. I'm not going to the tail of the hydrocephalus, grade 1, 2, 3, 4. How do we treat? How do we go? But you should know that there is the things post-hemorrhagic hydrocephalus is the dreaded complication of any IVH. So grade 3 or 4, if you are landing with the hydrocephalus, take away your brain matter. You are putting the shunts, you are doing IVDs, you are doing the stabs. So many things happen there. So this thing happens even with the PVL, the porencephalic cyst and asymmetrical ventriculomegaly happens with the grade 4 IVH. So how to prevent the IVH? Prevent the prematurity. For any disease, prevent the prematurity. So what is WHO is working on now is the prematurity factors for the mother and prevent them actually. Prevent the risk factors, we already discussed. Drugs, only antenatal betamethasone or the dexamethasone is a proven, and it reduces the odds by half. So RR for IVH for antenatal steroids is 0.47. So it means 53% reduction happens here actually. Prophylactic indomethacin earlier was given, now it is off now. Same nowadays we are giving this paracetamol, but it is not not as a prophylactic doses. Pancream may help, but has many side effects. Phenobarbital, vitamin K, E, are still not proven. So only thing which happens proven is the prematurity prevention, preventing the risk factors, and the drugs is only the betamethasone, or I mean to say the drugs or the steroid. So preterm is a vulnerable brain. Migration you have understood. Preterm brain injuries are 4 or 5. PVL preventable early detection, IVH preventable serial monitoring should be there. Not going into details of I think, yeah, 855. Okay. Thank you. I think in the last segment, little
Thank
fast.
you, Dr. Kamal. It's a very, very tough topic to deal with when we are talking about IVH also, and white matter injury also, and PBL classification. I know this is a very tough topic to discuss, but I'm sure the recipients, the people who have been listening to you, have been benefited. And definitely there will be questions. I request Dr. Priyanka to take up the questions if there, and then we can have some discussion on this.
Yes, sir. Sir has very beautifully summarized like about how neurons are formed and how migration occurs and why it is important to know about it. And sir has beautifully summarized about PVL, pathogenesis of PVL and IVH. Antenatal interventions are important, and survival is just not important. Intact survival is important. So it is a very good message, very beautiful message that everybody should take home, that intact survival is very important and treatment is important definitely, but we have to prevent it. And I think nursing care is very important. We
Yes.
should train our nurses that how to handle the babies, because we cannot handle the baby at every time. So it is very important to train our nurses how to change the diaper, how to give the boluses, how much. Sometimes they give bicarbonate. I've seen that they give bicarbonate like in the syringe, not a slow bolus. So very, very important. Small things can make a huge difference. And question I don't see, sir. There is one question somebody has asked. Nibha Mohanty has asked to show the diagram, but which diagram? I don't know which diagram she wants to see.
The algorithm or the diagram? I am not able to see the question. So
Okay, one question
if
is
anybody wants to read
pending.
if somebody wants to read more in detail, this article is actually this what I presented is more from the lens set. There was a beautiful article on this, the migration and this the zones which they have shown, and that was published in 2011. 11 or 12, that was the time. So I can share the article if they want. That was a beautiful article summarizing this thing. Whatever I have made in the first part of that presentation is from there actually.
Okay.
So
Jane
even
has role of erythropoietin.
role
in
of erythropoietin as a neuroprotection was there a lot. We discussed a lot, but finally what happened is then the ROP incidence started increasing and all those things. So it went off actually from there. Otherwise, erythropoietin still has a role in neuroprotection.
And at birth, delayed cord clamping also to add
Sorry?
on. Delayed cord clamping, sir. Delayed
Yeah,
cord
delayed cord
clamping
clamp.
is
Sorry,
also
I missed on that that part. Delayed cord clamping as antenatal this factor should be done, and it has been shown to prevent the IVH, even though the RR was around 0.8 or something, but it has shown to prevent the incidence of IVH in the preterm babies. It should be done, but not less than 28 weeks. It is still the milking and the cord, this delayed cord clamping has still not been shown as a benefit too much, but less than 34 weeks, yes, it has shown a decrease in incidence of IVH.
Okay. And how
Sorry,
do
I
we
forgot. It should be
screen?
important. Very
How
important.
do we screen for
They actually showed a
IVF?
reduction in IVH. The initial observation was that it reduces IVH, and then kept on using it, and in more trials, Magpie, Magnet, Act, Maxwell, and now Magenta.
Yes.
Now from IVH they shifted to the neuronal injury and ultimately cerebral palsy. So I think more or less Foxy, WHO are recommending it to be used less than 32 weeks. Myself, I'm not sure, Kamal, how often your obstetricians at your place, and Priyanka, you also, how often the obstetricians are using Maxelf in less than 32 weeks, and more important, less than 30 weeks? Are they using it for
Yes,
prevention
sir.
of
Sir, we are
Really?
using routinely for all the babies who are less than 30 weeks, like for the mothers who are less than 30 weeks presenting. So our obstetrician is too much convinced with this part that it has to be used. So all our obstetrician use,
correct?
yes, less than 30 weeks they are using.
So
For
you
5 days they
also
give max actually. Sorry, sir.
So your voice is
then 4
breaking.
gram bolus. Yeah,
Yes,
they're
sir.
using both and as well as infusion, right?
Yeah, as an infusion for around 3 to 5 days they were using it. So
Right.
there is a evidence also, sir, proving this. So our all we have 6 gynecologists in our medical college. So 5 of them use it judicially a lot actually.
Right.
At
So
our
I
center also,
Like,
it is obstetrician specific. Some
yeah.
people
right.
are using, some are not using.
So I think as a neonatologist, this should be our responsibility to convince our obstetric colleagues, because once WHO is saying less than 32, the 2016 document says less than 32, and less than 30, more or less every committee is saying use it. So one strategy can be Maxel, which is little underutilized as of today.
Yes, sir.
Steroids you did mention, it will be important. Hemodynamic instabilities are very important. Not using boluses will be very important. But let me ask you a very philosophical question around this topic.
Yes, sir.
Whenever IVH happens to any baby, any newborn, parents go discuss, see the other obstetricians, the other neonatologists, and they come back with this question that we were told that IVH is preventable, but why it happened to my baby? So what will be your pragmatic answer to these type of issues? Because I know that it does happen all around, all places, despite best of our care. So how to satisfy them?
Okay, sir, I started with the thing that after ROP, my concern is IVH because ROP is the current medical legal issue. The next would be definitely the IVH or the PVLs.
Correct,
Why this baby
correct.
this happened? That's why I started with the first line that this is like a nightmare for the obstetrician. So now, if a parents come to you for this part, so the first I always counsel them in the antenatal period that this baby is getting born less than 30 weeks or less than 32 weeks. Usually more than 32 weeks, it rarely happens. So it is
Right,
happening less than 30 weeks. So these babies are bound to have these complications. So usually we tell them all the complication and we get signed, tell them this can happen because your baby is getting prematurity. But we are trying to prevent the prematurity. But if we are not able to do so, we'll try to handle most of the issues. The ROP is a treatable and a preventable disease, but now it can be prevented and treated also. IVH, even if you get, we can prevent it, we can try it our best, but if it happens for some grade 1 or 2, we'll handle this. But if it is happening 3 or 4, it means your baby's brain was actually too premature to handle this much of a pressure, and this baby had an infection, this issues. So your babies can happen to this. And we start screening with the ultrasound on the day 1, day 3, day 7. That is a protocol, we don't break that protocol. So we tell them आज हमने स्कैन किया था, उसका ठीक चल रहा है, आज हमने किया था उसका प्रॉब्लम आ रही है, ये उसकी स्कैन की रिपोर्ट है. Then we tell them on day 7 it is this much, this is the report. So if by day 7 is not there, तो अब आप 90% टेंशन कम कर सकते हो कि आईवीएच नहीं होगा. बट इसके बाद भी हो सकता है, हम 28 डेज के बाद आपको दोबारा करके बताएंगे. So we
correct.
keep on getting them involved in this process so they don't find a sudden answer that, oh, my baby getting an IVH. And we start priming them at the start in the antenatal period. And that is very clear with our obstetricians that you have to get us these babies counseled, the mothers counseled, parents counseled, because otherwise they will say कि हमें तो बताया नहीं था, ये भी हो सकता है, ये भी हो सकता है, we could have gone to another hospital, all those things. So we try to involve them with the complications like mother or the neonatologist so that you are a part of the treating team rather than that we are just telling you. And we get them signatures, obviously, because the medical legal
So
issue.
we are trying to tell them as a group that nothing is 100%
Yes,
preventable. We
yes,
cannot 100% prevent IVH, white matter injury. These are all strategies, whether it is prevention of prematurity, which is not in our hand, Maxelf, steroids, hemodynamic instability, PDA treatment, feeding, nutrition, everything is relative. There is no 100% guarantee, 100% way of preventing. So that is why it's important in this era of medical legal problems to take it at the beginning that all these complications can happen. We can only try to minimize them, but we cannot. It cannot be IVH free word ever. It cannot eradicate these disorders. Are not like infections which can be eradicated from the world. These disorders will remain today, tomorrow. We can wind up the session.
Yes.
And so once PVHI has occurred, suppose
Hello?
grade 4 hemorrhage. Am I audible, sir?
Yes, you are audible, Priyanka.
Okay.
Yes.
So once PVHI has occurred, suppose grade 4 hemorrhage has occurred. So otherwise baby is doing okay. So do we counsel for withdrawal, or how do we counsel the parents then?
So again, the same thing, Priyanka, that we keep them involved from the start. So once if the PVH has occurred and the parents know about everything, so we give them these options that these babies will have some mental issues. What they will happen, we are not sure about at this point of time. They may become at 6 months, they may come at 1 year, may come at 2 years. We can keep on following them at that point of time. But usually withdrawal of care, in our scenarios, we don't tell them for the withdrawal of care. We tell them that there is a prognosis which is guarded, and we keep on taking signatures and keep on explaining them that right now there's nothing, but with time there can be the issues. So PVHI is something of that sort actually. If it is unilateral, still they come up better with this because it doesn't affect too much of your mental issues. So they get some problems, but I think if the babies which we have followed till date, they have issues, no doubt about they have issues. I think almost I would say 90 to 99% they have the issues. But there are minor issues which the parents will accept with time.
Jane has asked that one question. Ideal modality for detection of
As a colleague, I can always say, Priyanka, that
yes, sir. Yes, sir.
सर आपकी ना बैंडविड्थ लो है मेरे को लगता है
हाँ, कोई बात नहीं. हाँ, मैं
आपका वॉइस ब्रेक हो क्या रही है सर
वॉइस ब्रेक हो रहा है. यस सर.
I'll stop my video. That may become better.
Yeah, yes sir. Now it is better.
Okay.
Yes.
So I think मैं उस पे कमेंट ये करना चाह रहा था कि after PHH also the morbidity is very high. But
Yes.
then as a physician, as a professional, I've seen this and I've realized this over a period of time. Let us not try to be God to the children.
Yes sir.
Let us not try to be judgmental about what is the future. We are not we are not astrological powers. We cannot predict 10% versus 90%. So we should tell them the facts and let them decide. They will always tell you, डॉक्टर साहब आप बता दीजिए क्या करना है, ले जाना तो ले जाते हैं, आप बता दीजिए कराना सर्जरी कि नहीं कराना. You should stand your ground that I cannot decide this. This would have been, and they will also say कि डॉक्टर साहब अगर आपका बच्चा होता तो आप क्या करते? Don't get into that trap. Just come out of the trap and say, no, this is not my child. This is your child. I'm a professional. Baby may have a problem. Very high chances, may not. You have to decide. So, and if you do that, many parents, they have already made up their mind to treat, to continue treatment. But they want to listen from your mouth that don't treat. And then they say, डॉक्टर साहब ये तो बच गया, ये तो ठीक है, इसका तो heart size बड़ा जा रहा है.
I want to say, exactly.
आपने बोला था कि इसको घर ले जाओ. So don't get into that trap. Always try to be safe in this era. Facts and figures are all right, but don't decide for them. And especially your own relatives, your own friends, your doctor colleagues, your hospital employees, never decide for them. Let them decide. Otherwise, you are getting into medical legal problems.
Sir, what we say, I say in my, like you started with that thing, slightly informal conversation. So I usually say that, देखो जी मैं तो अपनी डॉक्टरी कर रहा हूँ, अपनी दिल से कर रहा हूँ, बट जो ठीक करना तो भगवान ने करना आपको. So we treat, he cures. तो हमारा काम तो ट्रीट करना है. अगर हम ट्रीट ही नहीं करेंगे तो फिर तो गलत हो जाएगा अगर मैं हौसला ही छोड़ दूंगा तो. सो वी विल ट्राई आवर लेवल बेस्ट एंड बच्चे बड़े होकर कैसे निकलते हैं वो हमें टाइम के साथ पता लगेगा. अभी तो बच्चा आप देख सकते हो, आप साथ में चेक कर सकते हो अगर आपको क्वेश्चन पूछना आप. सो वी स्टैंड विद द बेबी, टेल देम टू कम इनसाइड एज अ फादर आल्सो. नाउ टेक अ डिसीजन हियर एंड वी गिव देम द पिक्चर्स ऑफ द अल्ट्रासाउंड दैट दिस इज द पिक्चर ऑफ द अल्ट्रासाउंड. एमआरआई अभी करवा सकते नहीं करवा सकते डिपेंडिंग ऑन देम. सो वी कीप ऑन टेलिंग देम बिकॉज दे कीप ऑन टेक द एमआरआई रिपोर्ट और दिस रिपोर्ट एंड go here and there, second opinion, third opinion, fourth opinion, because India is like a doctor shopping area. So that keeps on.
Correct. So thank you so much. I think we have come to the end. It's already 1 hour, 10 minutes. So maybe final comments from Priyanka and then we say bye.
So can
Yes.
we take some questions? Two,
Yeah,
three
if there
questions are there.
any, please go ahead.
Yes, sir. Jane has asked ideal modality for detection of PVL and when should it be done?
PVL, the ideal modality currently is the MRI. Because the ultrasound, already we have discussed, the ultrasound picks up only 5 to 10% of the cases, the rest, because that too the cystic PVL. Nowadays, since we are dealing with the non-cystic PVL, so the ideal modality is MRI. And if you have a software for a volumetric analysis in the MRI, so the volume loss can be detected with the MRI nowadays. But you have to have a software for that in your MRI. But otherwise, the hyper echoic lesions which are not picked up in the ultrasound, the hyper intense lesions can be picked up in the MRI. So the current modality is an MRI. If you have a volumetric analysis, the best one. So and it should be done at an equivalent age of the term baby. So 40 weeks is an ideal time when we should do an MRI. Less than 40 weeks, usually on the myelination issue, so many things are happening. So the 40 weeks plus is the ideal time. If you say one answer, the equivalent to the term, that is 40 weeks. Does that answer the question?
Right.
Yeah.
Yes, sir. And somebody has asked the name of the article that you mentioned, I think for
I can
PVL.
share the article, Priyanka, with you. I think आपका share करूँ. That is a Lancet article. That's a very beautiful article. It's a review article you can get in the section of neonatology and the perinatology section, the AAP reviews perinatology section.
Right.
Once you go to the pediatrics, this is published in the AAP I said in the Lancet. So that is a beautiful article, not in the AAP, in the Lancet. That is another article AAP. So I can share that article with you.
Okay, sir. And sir, Dr. Shambhavi has asked that only CT scan is available at her center, and when should we do it in a preterm poor patient?
No. Don't get that wrong. CT scan is not a modality. I would say that part. I think Priyanka and Sir Pankaj sir would agree with that.
Yes.
The CT is not a modality to pick up the diffuse examination. CT is a modality for the hematomas, the bleeds, and the acute things happening. So CT, avoid sir, CT is not a modality which should be used to pick up the PVLs. IVH can be picked up, which is as good as an ultrasound. So for IVH, the ultrasound is a very good modality. For the PVL MRI, the CT scan should not be used as a modality for this thing, sir. Try to get an MRI if possible. Even after discharge, you can do that. You may need to sedate the babies or may need to pacify the babies for that. That is something, sometimes it happens. But otherwise, nowadays MRIs are coming up little faster. MRIs are coming up with this.
Right. So that's all, sir. That's all questions are there. All questions answered.
I think all the questions have been answered to the fullest.
Yes, sir.
So thank you so much, Dr. Priyanka, and thank you, Dr. Kamal, and thank you, Gaurav, ICH, IAP Delhi for this platform. I think those who are still there must have definitely their knowledge has been updated and in managing the patients. I think I've seen that many times after didactic lectures. Once the discussion happens, that improves your day-to-day working more than the theoretical part of it, but both are equally important. With these words, okay, bye-bye. Thank you so much.
Thank you, sir. Thank you for giving me the opportunity to discuss all this
See you some other time.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, Priyanka.
You're all most welcome. You're such a dear. Bye, Priyanka ji.
Bye, sir. Thank you.